Welcome to the deep dive. Our mission today is focused entirely on one critical operational update for emergency medicine practitioners across the Southwest. We're distilling the new regional standard for managing minor traumatic brain injury patients, specifically those who present with abnormal CT findings. This deep dive is all about SWIFTIE. That's the Southwest Initiative for Traumatic Intracranial Event Evaluation. Okay, let's unpack this a bit. Minor head injury, MHI. It's a constant fixture in our emergency departments, isn't it? We're talking around 1.4 million attendances annually across England and Wales. So yeah, huge numbers. And we're looking at quite a big change in how we manage those patients who, clear the trauma bay but still have these minimal CT findings.
Yes, and what's fascinating here is how close we seem to be to achieving compliance with MTBI, yet we were sort of falling short in practice. The current NICE guidance, NG232, it's excellent, fundamentally sound, but it left this vacuum, really, this ambiguity regionally. What exactly constitutes a surgically significant abnormality or a clinically important finding, specifically here in the Southwest? Historically, that lack of clarity, it defaulted us to, precautionary admissions, time-consuming 48-hour admissions, often, even when the actual clinical risk was demonstrably quite low.
Right, so we've kind of been inefficient by default, just to err on the side of caution.
Pretty much, yes.
And the SWIFTIE protocol aims to reverse that trend, moving us away from ambiguity towards a more structured, evidence-based approach, and that's centered on the Modified Brain Injury Guidelines, the MBIG criteria.
Precisely. The goal is twofold, really. One is compliance with NG232, specifically with recommendation 1.4.15, and crucially, achieving regional consistency. We need every ED in the Southwest operating under the same clear definitions of what needs that neurosurgical referral after a CT, and importantly, what can be managed safely, locally, or even discharged.
Okay, so if the issue was historical inefficiency, let's talk about the cost of that, because this is where the data really shows the scale of the previous waste, doesn't it?
It does.
Estimates from NHS England suggest this standardization protocol could save over, 1,098 avoidable admissions per year just across the Southwest region.
That's the real takeaway here, I think. The realization that a significant chunk, maybe around 90% of our current admissions for these minor TBI patients with minimal CT findings, while they were driven by that historical ambiguity and perhaps risk aversion, not always genuine clinical need.
Wow, 90%.
Yeah. And translating that into capacity, we're talking about roughly 2,196 bed days saved. That frees up resources and delivers a direct financial benefit of over £2.26 million annually for the system. Huge potential.
That's a staggering capacity injection just from achieving clarity. So the new system introduces stratification, helping us discriminate precisely between findings that are merely radiologically visible and those that are genuinely clinically important. Now let's get into the core mechanism then. The entire new system hinges on the radiology report, specifically including the MBIG score. This stratification tool, it's based on validated research, right? Joseph et al. From 2014.
That's correct. It's designed specifically to safely guide discharge decisions based on the size and type of the lesion found on the CT. So when you see that CT report back, the radiologist should categorize the injury into one of 3 MBIG groups. Perhaps for clarity, let's group them by the action required.
Good idea. Makes it easier to remember.
Right. So think of MBIG 3 as a sort of code red group. These are findings that absolutely mandate immediate neurosurgery referral and a bespoke treatment plan. No ambiguity here. These are the injuries you expect, the ones you'd never miss. An extradural hematoma, any intraventricular hemorrhage, significantly displaced skull fractures, or subdural hematomas, SDH, that are 8 millimeters or greater in depth, or large intraparenchymal hemorrhages, IPH, same size criteria, or extensive subarachnoid hemorrhage, SAH.
Okay, that's the clear neurosurgical pathway defined. So what about the intermediate group, the ones we manage locally but still needs, close attention?
That's MBIG 2. These findings require local admission for observation and, crucially, referral into the specific SWIFTIE follow-up service we'll discuss later. The key metrics here are those intermediate sizes, things like a non-displaced skull fracture, an SDH measuring between 4 and 7.9 millimeters, and IPH also between 4 and 7.9 millimeters, or SAH that's limited to one hemisphere but involves more than 3 sulci.
Got it. Intermediate size, intermediate pathway local admission, and finally, the group where the biggest shift in practice occurs, the target for early discharge.
Exactly. That's MBIG1. These patients are deemed suitable for discharge straight from the emergency department, after an appropriate observation period, of course, and with referral to the follow-up service. These represent truly minimal findings. An SDH that's 4 millimeters or less, an IPH 4 millimeters or less, or SAH involving just 3 sulci or fewer.
And the success of this, well, it really hinges on getting that MBIG score clearly stated in the report from our reporting colleagues, doesn't it?
Absolutely essential. And we know the major reporting services, Everlight, Medica, TMC, they've all agreed in principle to include the MBIG score. That's vital for making this workflow effective across the entire region, regardless of who reports the scan.
Okay, great. So let's move to where the rubber meets the road, the new ED workflow itself. You get the report, you have the MBIG score. That score, combined with your standard clinical assessment, dictates the pathway. But before even considering discharge for any patient, we absolutely must confirm the basic inclusion criteria are met, right?
Yes, absolutely. The foundational criteria are strict, and they apply across the board if you're thinking discharge. No other injuries or significant social factors requiring admission. That's key. You need confirmation of a responsible adult present to observe them at home for at least 24 hours. Their GCS must have been 13 to 15 at presentation, but crucially, now be firmly back at GCS 15 or whatever their normal baseline GCS is. And of course, no focal neurological deficits or any pupillary abnormalities. Those are hard stops.
That sets the necessary safety floor. Okay. But, EM is rarely black and white. We've laid out the radiological criteria with MBIG. But what if you have an MBIG-1 patient, they meet all those criteria on paper, yet you, the treating clinician, are genuinely uncomfortable? Maybe there's a language barrier or subtle subjective symptoms that worry you, or perhaps the patient is on antiplatelet medication. Does the protocol allow for that clinical override?
Yes, and that's absolutely critical. A strong protocol guides, it supports, but it must never replace clinical judgment. That's paramount. If the clinician has an overriding concern, perhaps the GCS isn't quite back to baseline, or they have persisting worrying symptoms like severe, intractable headaches or persistent vomiting, or maybe significant drug or alcohol intoxication clouds. The picture then, admission is still the right course. The protocol defines the minimum standard for considering safe discharge. Clinical concern always trumps the MBIG score if those core discharge criteria aren't fully met or if there's another compelling reason.
Excellent. That's reassuring to hear explicitly stated. Okay, so focusing back on the 2 low-risk groups where discharge is the goal, how do the MBIG-1 and MBIG-2 pathways differ in terms of, say, admission time and immediate management?
Right, so the MBIG-1 pathway is the most streamlined. If all those discharge criteria we just discussed are met, they're typically discharged 6 hours after their first observation, assuming a satisfactory senior clinical review confirms stability at that 6-hour mark. And critically, they are immediately referred via the digital platform Refer Patient for that structured telephone follow-up.
6 hours and out, with follow-up arranged.
Okay.
And MBIG-2.
The MBIG-2 pathway still involves a local admission. These patients are admitted to a local ward, usually medical or CDU, for a 48-hour observation period, then discharged as stable. A key clinical point for the admitting teams here, highlighted in the source material, is this. Unless there's an overriding clinical need for anticoagulation for another reason, these MBIG-2 patients should receive no low molecular weight heparin for those first 48 hours of observation.
Ah, that's an important detail. No prophylactic LMWH for 48 hours in MBRG-2.
Correct. And they too, upon discharge after 48 hours, are referred immediately via Refer Patient for the same structured follow-up service as the MBIG-1 group.
Okay, so we've essentially gone from a culture of potentially admitting almost everyone with any finding to only admitting the MBIG-2 group locally, and even then, just for a defined 48-hour period, not indefinitely. That's quite a shift. Which brings us neatly to Section 4, the essential safety netting, because we've shifted some of that inpatient monitoring burden, but it's been replaced, hasn't it, with a structured, proactive system. Tell us about the specialist nurse-led SWIFTIE follow-up service.
Yes, this is really the cornerstone of making the early discharge pathways safe and effective. This structured service is designed to replace that historical, often patchy reliance on GP follow-up, which wasn't really appropriate for this cohort. It's a system of scheduled telephone reviews. The structure is quite clear. The first call happens the very next day after discharge. This focuses specifically on those highest volume MBIG-1 patients discharged directly from ED. And this call uses a standardized questionnaire, which was actually developed in collaboration with occupational therapy, to screen for any immediate post-discharge deterioration or developing issues like worsening headache or confusion.
Right, an immediate check-in the next day for the ED discharges. And then there's a second call.
Yes. The second call takes place between day 5 and day 7 post-injury. And this one applies to both the MBIG-1 patients discharged from ED and the MBIG-2 patients after they complete their 48-hour admission. It's a slightly later check on recovery trajectory.
And this is planned as a full 7-day service eventually.
That's the aim. Initially, as it rolls out, weekend cover for the calls might be handled by the neurosurgery resident doctors, but the intention is absolutely for a full 7-day nurse-led service to provide that consistent follow-up. And the referral mechanism itself is important too. It uses a bespoke electronic form within the existing refer-a-patient platform, which everyone in the Southwest should be familiar with. It's designed to capture all the key data points efficiently: GCS on arrival and discharge, anticoagulation use, comorbidities, and crucially, a direct copy-paste of the CT report text itself.
Makes sense. Keeps it simple.
And significantly, for patients over 65, a frailty assessment score will be included on the referral. This initiative is supported by the NHSE Southwest Frailty Improvement Collaborative. It rightly acknowledges that frailty is a critical variable. It might necessitate different discharge planning or extra support, even if the patient's brain injury itself is classified as radiologically MBIG1.
That frailty integration is excellent. It recognizes that, radiological finding doesn't exist in a vacuum. The patient context is key. And looking even longer term, I understand there's a planned partnership to develop an EPROMS platform for automated long-term follow-up.
That's right. The idea is to capture patient-reported outcome measures electronically further down the line. This would help optimize referrals into specialist head injury therapy clinics and generally improve care beyond the current standard, really tracking that longer-term recovery.
That sounds truly proactive safety netting, extending well beyond the immediate 7-day period. Very promising.
Okay, moving finally to patient communication. This is vital. When discharging these patients, particularly the MBIG1 group from ED, we really must focus on educating them properly. Managing their expectations about recovery is key to reducing anxiety and preventing those unnecessary reattendances.
Absolutely. We need to reassure them. It's so important to convey that recovery is expected, but it often takes time, usually around 2 to 3 months, for symptoms to fully resolve. And that up to half, maybe 50% of people with even a minor TBI experience some post-concussive symptoms. Things like mild headache, feeling tired or fatigued, maybe some irritability, difficulty concentrating. We need to tell them this is actually quite normal.
Yes, normalizing those common symptoms is crucial. And rather than giving them a huge, long list of instructions they won't remember, the most critical focus has to be reinforcing the absolute return triggers, the red flags. They must understand they need to return to the ED or call 999 immediately if they experience any loss of consciousness, become difficult to wake up, notice clear fluid leaking from their ears or nose, develop a severe persistent headache that isn't relieved by simple analgesia, get neck stiffness, or notice any progressive weakness or numbness in their limbs.
Those are the non-negotiables. And focusing on some specific recovery advice that maybe practitioners sometimes forget to highlight, emphasizing they must not push themselves too hard. Rest is important. And specifically advising them to avoid reading small text or staring at screens, computers, phones for extended periods, particularly early on, as concentrating too intensely can really worsen symptoms like headache and fatigue.
That's a very good point, often overlooked.
And reminding them they must not stay at home alone for the first 48 hours after leaving hospital. That responsible adult observer is key for that initial period.
Absolutely. And of course, the standard avoidance advice. No alcohol or recreational drugs while recovering, and absolutely no contact sport, things like football or rugby, for at least 3 weeks, possibly longer depending on recovery. Plus, they must avoid driving a car, motorbike, or bicycle until they feel fully recovered and confident their concentration and reaction times are back to normal. They need explicit advice on driving cessation.
Okay, fantastic. So, recapping. We've covered the significant shift towards stratified TBI management here in the Southwest, really nailing down the definitions of surgically significant and clinically important findings through the MBIG score. This standardization feels like a real game changer for managing workload and ensuring consistency across all the region's emergency departments.
I think so. This initiative is fundamentally about achieving clarity where there was ambiguity. It's about eliminating that burden of unnecessary inpatient monitoring, which, as we discussed, was often driven by that ambiguity rather than need. And crucially, introducing robust, proactive safety netting via the SWIFTIEE telephone review service and the planned digital tools. It really represents an improvement in patient care that also happens to deliver significant system savings. It's a win-win.
So what does this all mean for you, listening as an EM practitioner in the Southwest?
Well, it means a clearer decision-making structure right there in the ED. It means increased confidence that your MBIG1 patients and appropriately selected MBIG2 patients are being safely followed up after discharge. And importantly, it ensures compliance with the necessary NICE guidance in a consistent, region-wide manner.
And this perhaps raises an interesting question for the future. The protocol documentation explicitly mentions embedding opportunities for research alongside this rollout. Specifically, it mentions the routine introduction of point-of-care biomarker testing looking at proteins like GFMP and UCHL1, initially planned at the MTCs in Bristol and Plymouth. So maybe the final thought to take away is to consider how this kind of technology, these biomarkers, might one day further refine our decision-making even before the CT scan, or perhaps help stratify risk within the MBIG groups themselves. Could it help us safely reduce unnecessary scans altogether down the line? That's a powerful thought as we look toward a truly optimized TBI pathway in the future.